Hello and welcome to the Fertility Foundations podcast, where we go into detail about how to prepare the foundations for a healthy pregnancy. We dive deep into the underlying causes for fertility issues and natural solutions, empowering you to take charge of your own path to parenthood. I'm Sandra Greenbank, nutritional therapist, functional medicine practitioner, coach and hypnotherapist, specializing in fertility, pregnancy and postpartum health. Today I'm speaking to Alpesh Doshi from Ivf London Clinic. Alpesh is a consultant clinical embryologist and a co-founder of Ivf London. He is also a co-founder and director of the Embryology and PGD Academy. Alpesh previously worked at the Centre for Reproductive and Genetic Health in the leading capacity as a director of embryology for 19 years and was pivotal in optimizing their success rates. He was also an honorary consultant at the Reproductive Medicine Unit at UCLH NHS Trust. He holds a postgraduate degree in human reproductive medicine and has qualified from the prestigious Imperial College School of Medicine. Alpesh is a diplomat of the Royal College of Pathologists and also an ASHRAE certified senior embryologist. He has been an executive committee member of several international embryology societies and holds a very active interest in promoting education platforms through these professional bodies. He was among the first scientists to bring the egg and embryo freezing technology of vitrification to the UK in 2007. He is a world-renowned expert in the biopsy of human embryos for genetic testing. He has also authored several papers in high-impact journals and written several book chapters, in addition to being an honorary lecturer at University College London, where he teaches embryology on 2 of the master's courses. I'm sure that you're really looking forward to hearing all about embryology from one of the experts on this subject. But before I get into today's interview, I wanted to let you know that the £100 discount code for my fertility course is still available for a little while longer, and that's if you're listening to this during July or August 2020. More information about my fertility course can be found if you go to the link by my Instagram page. So if you go to my Instagram profile, my handle is Sandra Greenbank _fertility. And to get the discount, you just need to put the code LOCKDOWN at the checkout. And please get in touch with by DM or email if you have any more questions about that course. But now let's get on to the main interview. Thank you so much for joining me on my podcast, Alpesh. I'm really excited to talk to you. And as you know, I've got lots and lots of questions about embryology. But just to start with, could you tell us a little bit about yourself and how you decided to specialize in embryology?
Sure. Thank you so much, Sandra, firstly, for inviting me to the podcast. Absolutely a pleasure, as always, to connect with yourself and your audience. So I decided to get into clinical embryology after I finished my undergraduate degree, which was in biomedical sciences. And then as a postgraduate qualification at that time in around 1997, there was very few assisted reproduction courses going on as a master's degree, which I did. And I was fortunate to get into one at Imperial College. And I finished that, and that gave me the platform to train as a clinical embryologist. I loved what I did, certainly even in my postgraduate studies. And it was when I joined as a clinical embryologist as a trainee, I absolutely loved the whole science, the science behind creating life, sitting under a microscope, creating life, performing ICSI, and so on. So that's how I got into clinical embryology. And now 24 years down the line, I'd like to think I've learned a few things about it.
Yeah, that definitely sounds like you have done. And what led you to start your own clinic then?
So I have always had a bit of a vision and a dream that one day I wanted to kind of have my own clinic. And I think it all stemmed a bit further when I had served about 19 years working for one fertility clinic. And I said, what next for me? And I always felt that one of the things that was lacking in the previous clinic I worked at was a one-to-one and a very personalized approach. And of course, when any clinic becomes busy to the point that patients feel that they are just a number, then it's one of those things that you really decide that what kind of care would you really like to give your patients and what do they really deserve. And of course, patients are there for the success rates. And we knew that we could deliver that in the sense that, we had got very good success rates in the clinic I was working at. But I felt what was really lacking was the journey or the patient experience. So I wanted to create a brand or a label of a fertility clinic which really had a personalized approach when it comes to patient care, and at the same time focused a bit more on the journey and experience of that patient. Of course, we're not here to guarantee a pregnancy, but certainly what we can aim to do is guarantee the journey. And that's what was the foundation of IVF London, or the concept of trying to create a bit of a different type of IVF clinic.
Yeah, I think you've definitely succeeded there, because I've worked with clinics in the past and I didn't feel like I fitted in so much, but I think you've got a great ethos, definitely. And actually, you have a wife as well who's very much on board and who's also a medic.
Yes.
And, it's lovely that you've kind of decided to make that change.
I think just to add to that, Sandra, apart from just creating a brand which focuses or is more patient-centric in terms of the experience, I also felt that there was a huge lack of clinicians or doctors trying to understand the holistic aspects of IVF. And again, I felt that, in my opinion, that was quite important to try and keep a focus on other holistic areas such as nutrition, such as reflexology, such as acupuncture. And this is what encompasses all the services at IVF London, should the patient want to embrace them. So we are one of the very, very few clinics that has this approach, whereby we would welcome patients to consider holistic aspects of a lifestyle change before they consider having IVF.
Yeah, I think it's still, obviously to me, it's kind of unbelievable that in 2020 clinics are still not embracing this, but you are, and I think that really, in my opinion, puts you at the kind of forefront of the type of clinic I would personally like to work with if I had if I needed IVF. But let's go back to embryology. So what does an embryologist do, and how do they fit into the picture of an IVF cycle?
Thank you. So yes, the embryologist is one of the key wheels of a fertility treatment from a patient's perspective. And of course, as much as the work may seem very much behind closed doors or behind the curtains, the embryologist is one of the fundamental people who would either make or break the outcome of your treatment. So what an embryologist does in a nutshell is grow the embryos, create embryos. So as you know, the journey for an embryologist starts at the point of egg collection. So till the point of egg collection, it is the consultant gynecologist who is involved in stimulating the patient with hormones to make the patient's ovaries produce follicles. And of course, those follicles should have eggs in them. So to the point of monitoring stimulation, or the first 2 weeks of the IVF journey, are in the hands of the gynecologist. Once the patient's follicles are ready to have the eggs extracted, that's when the embryologist steps in. So at egg collection, the gynecologist will drain all the follicles, and all the follicular fluid will be screened by the embryologist, and all the eggs are identified and extracted and kept in the laboratory till further action. So what the further action involves is, on the same day as the egg collection, the embryologist would inseminate the eggs, i.e. put the sperm and eggs together via two different methods. It's either IVF, if the sperm count is normal, or perform a procedure called ICSI, or rather called intracytoplasmic sperm injection, if the sperm quality is low. So this is the point of what we call fertilization or insemination. And then for a period of another 5 days, the embryologist is nurturing those embryos in very specialized culture media, which feeds the embryos with the nutrients that they need. And apart from feeding the embryos with the nutritional requirement, the embryologist is also studying the division of these embryos, right from 2 cells to 4 cells, 4 cells to 8 cells, 8 cells to 16, 16 to 32, and 32 onwards. So by day 5 or 5 days after egg collection, the embryologist is expecting to see the embryos contain over 200 cells. Now, it's got to be understood that, say for an arbitrary number, let's say 10 eggs were collected, we would expect 7 of those to fertilize. And out of those 7 fertilized eggs, we would expect around 3 to 4 blastocysts formed by day 5. And it's usually on day 5, the patient comes in for an embryo transfer, and the embryologist would identify the best embryo through various methods, through selection of, say, time-lapse images, and I'll talk a bit more about that later, about how the embryologist looks at the finer details when the embryos are developing, to give the embryologist the confidence or understand what are the aspects of the development of this embryo that gives us the signals to suggest that this is the strongest embryo which will lead to a baby. So this is the role of the embryologist in a nutshell. They are creating embryos from eggs and then monitoring those embryos for 5 days in the hope that they will pick up signs and signals to suggest which of your embryos is the best embryo to transfer back into the womb and hopefully result in a pregnancy.
Okay, so when a female patient gets told that her eggs are poor quality, then, which can be obviously absolutely devastating, what does this actually mean? And what are the signs and symptoms that you would look for in an egg to try and establish this? What do you know about egg quality in that respect?
So we know for a fact through the very limited research that is around us that the powerhouse of an embryo is the egg, okay? And we also know that women, as they age, their egg numbers and egg quality deteriorates in time. So typically, if you were to compare a woman who's 35 years old to a woman who is 40 or 41 years old, there will be 2 paramount differences in their fertility. One, which is the number of eggs that they can produce, and second is the quality of the eggs that they produce. And numbers is not so much of an important parameter as much as is quality. So when you hear of doctors saying that the egg quality is not good, that is potentially extrapolating from the fact that their embryos were not of very good quality. Of course, it's not an exact science, Sandra. You can never be 100% that the impact of a poor quality embryo always stems from a poor quality egg. It is an extrapolation. And usually that extrapolation is always made based on female age and ovarian reserve. So again, you know, the conclusion when we say that someone's eggs are not good quality may not necessarily always mean that the eggs are not looking good under the microscope. Sometimes they are. So sometimes as embryologists, we will look at the eggs under the microscope and say, well, you know, there's some clear abnormalities here that we can see that we don't like. However, 8 out of 10 times, the eggs don't look bad under a microscope, but it's more those hidden aspects that come out in the 5-day journey of an egg developing into an embryo that leads an embryologist and a clinician to say that I don't think these embryos are good quality, and as a result, it could extrapolate to the fact that it's the eggs that are not of good quality, because we know that the egg is predominantly the powerhouse of the embryo. But I do not want to ignore the contribution of sperm, and probably this is something we're going to be talking a bit later.
Yeah, that's really interesting as well, because I think that men, a lot of the time, or at least in the past, I think it's changing now, but they have kind of almost been ignored, and it's sort of, if I think that as women, we can be quite quick to judge ourselves or take on the blame, and but actually it's 50-50, isn't it? But I've heard that after kind of day 3, and what happens after day 3, there can be some sort of again, could there be a clue there, depending on what happens after day 3, depending on whether it's the egg or the sperm? Is that?
Sure. So I'll talk a bit more about the specific of the embryology. So as I said, on day 0 is when we collect the eggs, just so that we can put this whole acronym of day numbers. Mm-hmm. So the day of egg collection is considered to be day 0. The following day is day 1, when we see signs of fertilization. And the following day after that, which is day 2, the embryo should be between 2 to 4 cells in development. And apart from just looking at the number of cells, we also look at the cleanliness of the embryo and how cleanly that division is. So that's on day 2, which is 2 to 4 cells. On day 3, the embryo should be between 6 to 8 cells. Now, in embryology terms or embryology language, the embryos are crossing a huge barrier when they go from day 2 to day 3. That is because the embryo starts switching its nutritional requirement. So it's a bit like human babies, in the sense that initially the baby is relying on supplies of nutrients from the mother. So the embryo as well, till day 2, is relying on supplies from the egg. But on day 3, the embryo switches, or a huge step happens, which is where it switches its energy production from relying on the mother's energy reserves and trying to create its own energy reserves. And we call this the embryonic genome activation. So the embryo starts making its own energy reserve, and it activates its own genome. So this is a huge barrier for the embryo to cross. And as much as the first 2 division stages, such as the 2-cell and the 4-cell, are based on using the mother's energy reserve from the egg, on day 3, the embryo has activated its own genome, and it's making its own energy reserve, which automatically tells the embryologist that these embryos are slightly better than choosing an embryo on day 2, because we have seen that the embryo has crossed that huge milestone. However, from day 3 onwards, there is still further funneling. So again, from an arbitrary number perspective, let's assume there's 6 day 3 embryos. It would mean that by day 5, which is blastocyst stage, we would expect around 3 to 4 of those embryos to develop further to blastocyst. So this is what the journey involves when you talk about day 2, day 3, and day 5. So whilst we have talked about that the embryo is dependent on the egg reserve till day 2, and on day 3 switches its energy production and take over production of that energy. However, there is a huge contribution of sperm from day 3 onwards as well. So what we call the paternal genome, the sperm provides a lot of its input from day 3 onwards. And hence, when we say that if an embryo did not make it to the blastocyst, that may well be because of the egg quality, we should not ignore the sperm, because the sperm also has a huge contribution to the creation of that embryo and further development of that embryo. And again, as you know, there is more and more research around the contribution of sperm, and how traditionally, 10 years ago, if a couple was not getting pregnant with their own eggs and sperm, as much as the focus would have been on changing the eggs or considering donor eggs, nowadays there are a lot more comprehensive tests that also look at the sperm health, and you may be able to direct a couple a lot more better rather than just saying use donor eggs. You may be able to guide them to potentially using donor sperm, which would have solved the problem.
This is incredibly interesting. I've learned something new there, and that's this just really does put the males right back into the center, isn't it, of the entire treatment. And I know that you've got a great urologist on your team as well, who I hope to interview as well, because his presentation when I saw him a couple of years ago just blew my mind. But I'm really interested to understand what's in the medium. You said that the eggs are put in the medium and it feeds the eggs. What's in that medium?
So it's a very complex solution that contains a lot of measured nutrients. So from an embryo's perspective and an egg perspective, one of the biggest, what we call energy substrates that it needs, or energy that it needs, is derived from sugars or carbohydrates. So as we all know, that the basis of energy in any cell is trying to obtain or break down the carbohydrates and obtain the energy reserve, or what we call the internal cell cycles or energy cycles that have to go on in cells. And we won't be, we won't get into too much complex detail about it. But the energy that is required comes in the form of some sugars, some polysaccharides as we call it. So in the culture media, there is pyruvate, there is glucose, so initially the embryo uses pyruvate as the energy substrate. And when the embryo is at the day 3 stage, it changes its metabolic requirement or energy requirement from pyruvate to glucose. So the medium that we have providing the energy to the embryos provides it with the amino acids, both essential and non-essential amino acids. It will provide it with the carbohydrates, as I said. It will also have some, some fat, some protein in it, some energy reserves, and most importantly, it has what we call human serum albumin in it, which will provide the protein aspect of the nutrition to the egg and embryo. So it's a very complex concoction of various measured energy substrates or energy reserves that the embryo needs in the culture media. But as I said, it needs to be very measured, because again, if any of these levels of carbohydrates or energy substrates exceed a certain level, then it can negatively affect embryo development. So a culture media has to undergo many, many years of research before it is released for clinical use, simply because there's so much research that has to be done about what is this right level of energy substrate that an embryo needs, what is toxic, and what is under. So it really has to be carefully measured, and that's when a culture media is made. Culture media is not made in-house. It is made by companies that specialize in a lot of quality control and a lot of what we call mouse embryo testing is done before it is released for human IVF.
That's so interesting. And it meant when you talked about pyruvate, and it brought me right back to learning about the Krebs cycle.
That's it, yeah.
In biology.
Yeah.
Okay. And so some women are, a lot of the time, I guess if they have fewer eggs and it's just not looking so good, sometimes they decide to put the eggs or transfer the embryos before blastocyst stage. And what is the thinking behind this?
So practices have really changed over the years. And I tell you, yes, as much as the universal practice is aiming towards all clinics going to blastocyst transfer, which is day 5 of embryonic development, simply because you can select the best embryo. However, if you have a patient, Sandra, who has only 2 embryos that are developing on day 3, sorry. So on day 3, you look at the embryos, she only has 2 good quality embryos then what would you do? Would you take a call of putting these embryos back on day 3, back inside what we call the natural incubator, which is the uterus, or would you culture them for another 2 days and then identify which embryos to make? Of course, there are pros and cons. The approach we take at IVF London, and my personal feeling about this is, I would wait till day 5 on all embryo transfers. Because for me, Sandra, it's not about just putting an embryo back. We don't realize, and this brings me back onto the holistics of it, how patients perceive an IVF cycle. So for the patient, as you know, the biggest or the most stressful time is that 2-week wait once an embryo has been put back into the womb. So for me, I would rather tell a patient that, I'm sorry, your embryo has not developed to the blastocyst stage and we're not going to be doing an embryo transfer, rather than put an embryo back on day 3 and then make them go through 2 weeks of injections and obviously the agony of knowing whether the cycle has worked or not. For me, it is very important to select the best embryo. And the way we can do this is by culturing the embryos to blastocysts. So as much as in the clinic I worked before, we had a protocol whereby if the patient did not have more than 2 good quality embryos on day 3, we would call them back on day 3 and do the transfer. And it's only if the patient had more than 3 embryos, we would take them to blastocysts. The practice that we have adopted at IVF London is, even if a patient has 1 embryo, we would wait to blastocysts. This stems from our confidence in knowing that the laboratory conditions are absolutely spick and span and the most ideal, and very much can mimic as close to possible to the uterus. And most importantly, it's also what we tend to forget, Sandra, is IVF is not necessarily just a means to get pregnant. It's also a means to understand why a couple are not getting pregnant so that we can give them a direction moving forward. So, for example, if a patient has had 3 embryo transfers and not been pregnant, and they've all been day 3 embryo transfers, then what is the most reasonable thing to do is see if these embryos make it to the blastocyst the next time. And if they don't, you put a closure on that patient in terms of using their own eggs. And also it helps us give a direction to the patient to say, I don't think this is working with your own eggs and sperm. Let's consider donation. So for a couple, it's very important to get also a direction in terms of which way they should move in their pursuit of fertility treatment. And an embryo transfer doesn't solve that. For that couple, it's a pregnancy, and we have a responsibility to make sure that we give them the best direction within the information that is available to us, provided you give yourself that opportunity to get that information, which is the journey of growing the embryos to the blastocyst.
Yeah, you made a really great point there, which I really agree with. It's not, the goal isn't to get pregnant. The goal is to have a healthy baby at the end of it. And if you get pregnant and then, you miscarry, or already that the chances are fairly low, then, that extra time that you then take going through that 2-week wait, and maybe the disappointment and all of the kind of drugs that your body then has to kind of deal with, and the recovery from that, that puts you potentially far further back than it would do to wait, 1 more cycle or maybe a couple of months and kind of try again without having all that trauma of a failed cycle. Do you agree?
I totally agree. And of course, the pursuit is always to try and get the patient have a healthy baby in their arms. And the way we do that through technology is that nowadays, you may have heard, we have technology that can screen embryos for genetic disorders. One of the reasons we know why embryos do not implant or result in a miscarriage, Sandra, is that the embryos have got chromosomal or genetic abnormalities. And this is not to kind of alarm anyone. This is a normal concept when it comes to embryology. So even in your youngest patients or your eldest patients, there's always going to be a proportion of your eggs that result in embryos that are chromosomally abnormal, which are not destined to implant, or even if they implant, they will result in a miscarriage. We know from research that 90% of the miscarriages that happen are happening because of a chromosomal or a genetic error in that embryo. Okay, this is nature's way of filtrating or keeping humans at the low end of reproduction. This is nature. So technology nowadays has developed to that point that we can screen these embryos. And screening these embryos for these genetic disorders or genetic aberrations can only be done at the blastocyst stage. So I get many patients who will come here and say, you know what, yes, I appreciate I'm 35 or 36, I've got a good chance of getting pregnant, but I still want to combine genetic assessment of the embryos so that we can further fine-tune and refine embryo selection in terms of which embryo to put back. So as I said earlier, for arbitrary numbers, let's imagine there were 6 embryos on day 3. Let's imagine there were 4 blastocysts that were formed. Now, to the embryologists, they could pick one of these 4 if they were not combining genetic screening. One of these 4 embryos could be transferred, it could implant, or it could not implant. However, if we combine genetic screening, which is again, as I said, done at the blastocyst stage, where we take a small biopsy of the embryo, and provided we have 1 or 2 normal embryos or genetically normal embryos from those 4 embryos, we then change our focus to only transferring one of those healthy embryos, genetically healthy embryos, which then further optimizes the success rates for the patient by another 20%. So, you know, a patient who has a 50% chance of getting pregnant with an unscreened embryo automatically pushes her chances of getting pregnant to around 70%. And most importantly, even if we don't focus on the pregnancy rate, what is really worth taking out of that is that the miscarriage rate is really, really low when you have a screened embryo transferred. So all this still goes back to the concept of why, as embryologists, we should be culturing the embryos to blastocysts so that we can also facilitate genetic screening. And once the embryos have been genetically screened, we can further optimize the chances of the patient not just getting pregnant, but reducing their miscarriage risk, and at the same time increasing the chance of having a live birth.
That's really interesting. And you're referring to PGS testing there?
Yeah, I believed in it for a long time. Yeah. And at Ivf London, more than 60% of our cycles are PGS cycles.
Okay, yeah. I know you've talked about this a lot before, and I think that, again, it's one of those kind of slightly, I suppose, controversial subjects, but it makes so much sense.
Yeah, absolutely.
Yeah. Okay. And talking about age then and egg quality, is it true that it drops off the edge of a cliff, age 35, for everyone, or do you see a lot of variation here? And if so, what do you think influences this apart from age?
It's a very good question, Sandra. The number of patients I see, the number of women I see who will tell me that, yes, I am 40, but I'm sure my fertility is very good because I've got a very healthy lifestyle. I eat well, I exercise, I have my regular periods, etc. So there's 2 aspects to a woman's fertility, Sandra, as I said earlier. One, which is the egg reserve, which is generally measured by a hormone in the woman's body called AMH, or anti-Mullerian hormone. And the other aspect which determines a woman's fertility is what we call enteral follicle count, or so-called resting follicles in her ovary. So the biology of reproduction is that when a baby is born, when a female is born, she has a lot of eggs in her ovaries. But as she ages, and even at puberty, more than half of those eggs have deteriorated naturally in the ovary. This is what we call atresia, or programmed cell death, or programmed egg death. This is nature. So the decline starts right from birth, Sandra, but it's only at puberty that those eggs that are left behind start maturing and releasing an egg. But the decline, even after puberty, is happening. It's happening naturally. But the sharp decline that we are talking about when it comes to the number of eggs, and more so, the quality of the eggs, and I think we should really focus our discussion on the quality of the eggs and not so much the numbers. The sharp decline comes after 37 years of age. So between 35 and 37, and of course, any age from 22, 23 onwards, up to 35, 36, these are considered to be very prime years when it comes to a woman's potential at reproduction. But after 37, there is a very sharp decline, not only just in egg numbers, which is not so much the concern as much as is the egg quality. And most importantly, the genetic aberrations or genetic defects that start in the eggs after this age. So, as I said earlier, the chromosomal errors or the genetic errors start to really kick in after 37 years of age. And hence, yes, the numbers are important. So there will obviously be a decline in egg numbers, but there is a much sharper decline in egg quality, which is resulting from genetic abnormalities.
Okay, that's interesting. And what are some of the tools and technology? You sort of touched on it a little bit before, but what is the tech that you now have as an embryologist that can actually make a difference to an IVF cycle?
Again, a fantastic question, because embryology has really developed in the last 10 years, Sandra. We to the point that we have got artificial intelligence algorithms whereby embryos are selected based on AI. So when we talk about tech, I would like to take you back in those days when we were not even able to grow embryos past day 3 because the culture media was not good enough to support the development. So not only has technology evolved in terms of the culture media being more refined to support embryonic development, but even incubators that we have nowadays are very, very swish and finessed to the point that we have time lapse in the IVF lab, which is nothing but an incubator which has got a camera which is taking images of these embryos every 15 minutes. And to the embryologist, it is relaying a lot of important information in terms of pictorial images of the embryos so that the embryologist can study how the embryos are moving from 2 cells to 4 cells to 8 and what are the aberrations or the developmental aberrations the embryo has shown in this journey from fertilization to blastocyst. So this is time-lapse. But to add to it, due to the time-lapse imaging, we also now have artificial intelligence algorithms which are built into the software of these time-lapse incubators, which can tell us as embryologists how the embryos are being scored. So we all know that whenever there is human intervention, there is subjectivity. So Sandra, you may look at an embryo and say, well, this is what I think about this embryo. I may look at it and say, well, this is what I think. So we have a subjective assessment. Whereas with artificial intelligence, there is no subjective element. The whole idea of incorporating tech in IVF or in embryology is to remove those subjective variations. And this is based on data that is collected from thousands of IVF cycles. So the power of that algorithm is very, very strong. So in summary, tech has developed to the point, Sandra, in the lab, whereby we are using machine learning to tell us which embryos are the strongest and which ones have the best potential to develop into a baby. And the future is very bright. Tech is also looking at automating a lot of procedures that we do in the laboratory, such as ICSI, such as embryo biopsy. So there's so much of research and development going around these days that I think in the next 5 to 10 years, we would be looking at really reducing the number of embryologists that we have in the laboratory, because the robots and the tech is doing a lot of the work.
That's so interesting. Yeah, that's it's sort of frightening, but at the same time, it's obviously encouraging as well. So I know the topic of improving egg quality is quite controversial, especially when we're talking about kind of natural ways to improve it. But what other ways are there that you can help improve egg quality apart from the tech? I'm thinking about drugs, and a lot of people have heard about DHEA.
Sure. So there is a lot of myths around improving egg quality. I'd like to be a bit pessimistic, Sandra, and say there's very little that can improve egg quality and egg yields. Yes, we have all seen cases whereby patients would have tried various holistic aspects, and I'm a believer in one thing fundamentally, which goes in your support. We are what we eat, right? So I believe that our nutrition has to really be paramount. To begin with, when a couple come here and say that, we have had IVF cycles, several IVF cycles, our egg quality is not being good, our egg numbers are not being good, I really first urge them or look at their lifestyle. And when specifically their lifestyle, we talk about nutrition. We all lead such a nuclear life these days, Sandra, that we really forget about how important nutrition is. We're so engrossed in our day-to-day work. We come home, we eat the most unhealthiest and very fast meals or processed stuff that we tend to really forget what is really required and what is really good for our body. So nutrition is very important. Out of all the holistic areas, I would say that if a couple ate well and perfectly well, including taking the right supplements that they need, then I think this is the most important thing to tackle in terms of improving egg quality. Going down the question of DHEA, again, there is limited research that has been done on DHEA. There is pros and cons. Not every patient can take DHEA. And of course, patients who have got high androgens in their body or have, PCOS or something like that. And of course, those would never be the ideal candidates because they have a lot of eggs, PCOS patients has. But what I'm trying to say that we need to select patients very carefully once we have done the background checks on their medical history, that they do not suffer from any kind of hyperandrogenism in their body. Now, going back to DHEA, there have been some very promising studies that have evolved from the USA. But like anything, Sandra, this takes time. The minimum time period that has been recommended for DHEA therapy is 3 months. Now, the balance comes when, or the debate comes when you have a couple or a woman who will say, you know what, I've got a declining egg reserve. I want to get on with treatment. As a clinician, if we say, well, please try DHEA for 3 months, and if the fertility declines further in terms of ANH, then that couple has lost out on one aspect of it. So it really needs to be carefully evaluated that which patients have got the ability in terms of time, in terms of ovarian reserve, to try DHEA therapy. All these therapies are a bit long-term. They just don't happen overnight. It's not a matter of just telling someone to take it for a week or two. It is a minimum of 3 months. So as much as the research is very promising about DHEA, it comes at a bit of a time expense. And of course, we need to identify the patients very carefully.
Yeah, that's really interesting. And also actually some of the promising research is actually only on women who are sort of around 40 or later. And, those are the ones who maybe do have more time constraints as well. So you've mentioned already, and I know this from working with you, and actually, you probably don't know this, but I've worked with IVF clinics before, and I decided a few years ago that I never would work with one again because I just didn't, I couldn't get over how kind of, it was just very jarring in terms of my outlook and my opinion on how clients should be sort of treated. And but I came across you, and I can't remember how, but I learning how much time and effort you spend in ensuring that your patients feel really well supported and looked after at Ivf London. I think that it's really encouraging, and you're very open to complementary practices. And you mentioned you've got nutrition, me doing nutrition, you've got acupuncturists, fertility coaching, and lots of other things as well being offered, which a lot of other clinics, they can have quite a negative attitude to this. So I'm interested to hear a little bit more about your thoughts about the importance of this for patients going through IVF.
Sure. So at Ivf London, there's a huge focus on patient well-being. And we use the word patient well-being in a very holistic sense. And I don't necessarily only want to refer this to nutrition, but the couple as a whole. So we will assess their well-being through several ways at the IVF clinic. Of course, our staff are so in tune with our patients. They know them by their first name. We have a very boutique service here, but most importantly, when I talk about patient well-being, we start off just by assessing their relationship, that how are they with each other, and what level of stress is there already that is built up. How can we remove some of that stress from their life? Because one thing we definitely know, Sandra, is stress is a negative predictor of fertility outcomes. So we don't want couples who are stressed because, the hormone cortisol or steroid cortisol is a stress-releasing hormone. And we know that, when cortisol levels are high, then the outcomes can be poor as well. There's limited research on it, but the research has been quite strongly suggestive of how stress can affect fertility. So based on that, this is where we start. If we feel that the couple are they're not quite ready because there's a lot of other emotion and stress that is kind of building up in their existing life, we will take them right back and say, well, I think you need some counseling. I think you need some coaching. We really need to address some underlying causes first, not necessarily medically, but even psychologically in terms of their well-being. But whilst the couple are going through these various aspects of psychologically balancing themselves, we can introduce so many of these other holistic aspects, such as nutrition, such as acupuncture, such as reflexology. I get many women who will ask me that, Alpesh, do you think acupuncture or reflexology will improve my chances of getting pregnant? And I have a responsibility of giving the right answer. That as much as the data may be quite limited, I almost put a question to a question. That do you think having reflexology is going to relax you? And if they say yes, it does, I'll say you don't have it then. Because for me, it's very important that I see a very balanced person who is not stressed during the IVF. So as much as a lot of these holistic angles that we incorporate in clinical practice nowadays, Sandra, have got limited evidence, and of course some have more than the other, and nutrition, I totally swear by it, because I believe we are what we eat, But these other adjuncts like kinesiology, reflexology, acupuncture, they have varying levels of evidence. But ultimately, all of this is purely to see if it can help the patient relax. So this is what my 2 cents worth is on how I feel that the patient really needs to be evaluated as a whole and not just from a medical perspective.
Yeah, I agree. There's the mind-body connection is strong. And, I'm by no means, I would never say, nutrition is the be all and end all, because if you can take all the pills and eat all the good food, but if you're stressed and running around and, then what you eat isn't necessarily going to even be absorbed, because stress actually does impair your digestion and absorption. And I'm a huge fan of acupuncture. I'm a huge fan of reflexology, but it's about the person, isn't it, as well? Because if you have a fear of needles, acupuncture maybe isn't right for you, because you're going to be stressed about having those needles. My husband's got a terrible fear of needles, and he once went to an acupuncturist, and he said it was just absolutely horrific. I just couldn't relax. And, maybe reflexology is better for you. But then if you don't like people touching your feet, then, that's not going to be helpful either. So don't force yourself to do something that isn't right for you. You have to decide what you need. So I totally agree with you there. But I'm glad to hear that you're on board with the nutrition, because obviously I'm 100% biased, but I think it's so important. If you haven't got the building blocks, how are you going to build your house? Right. What about fertility preservation? Not necessarily. So I'm thinking more about those who kind of might want to put off having a family for their career. So that egg freezing is becoming more talked about in the mainstream media. What are your thoughts around this?
So I'm definitely a proponent for fertility preservation, and I feel that, in my opinion, it's an insurance policy that many women should consider whilst they're trying to climb their career ladders or education ladders. And of course, we know, one thing we're really lacking, Sandra, globally is fertility education. The number of women I see in my fertility clinic who say that only if I knew 5 years ago or 7 years ago that whilst I was busy not trying to have a child, if someone had told me that I could have considered egg freezing, I would have done that in a heartbeat. We spend so many years of our lives trying not to get pregnant. And then when we're trying to get pregnant, we have all these other issues that really kick in. So I believe that, like how we have so many choices nowadays, such as freezing the stem cells from the cord blood. I have frozen stem cells from both my kids, when they were born. And that's not because, I knew that it's going to come in handy one day, but it's a bit of an insurance policy. And we have the technology nowadays, so why not? So this is my take on fertility preservation. That I feel that if someone, and again, this may be very subjective, this is my opinion, and I may be biased, but whilst we have the technology of preserving eggs very successfully nowadays, because the technology has really become very good when it comes to egg freezing, why should women not consider it, especially if they are, say, 32, 33, and they're like, I still have a way to go. I can't see myself having kids for another 4 or 5 years. And of course, by that time, the quality of the eggs may have changed anyway into a bit of a natural decline. Then why not consider egg freezing? And nowadays, Sandra, IVF protocols are very, very finessed. We are no longer using what we call long protocols. Nowadays, we're using very short or ultra short protocols to stimulate women with much milder stimulation doses of hormones. So women don't even feel the effects of the hormones that they're being injected with. So the whole process of egg freezing can be completed in 2 weeks from their period. So as soon as the patient has their period and there is no priming needed, they literally come to us on the first day of their period. We will start injecting them with the hormones on the second day of the period. And by 2 weeks, they have got eggs collected and in the freezer. It is that simple. So whilst the technology is that simple, yes, of course, cost is a factor which everyone needs to consider. But whilst it's an option, whilst the process is pretty straightforward, whilst every woman can fit in the whole process very conveniently when it comes to their work and life, their home, their work, etc., the whole process can really be fit in quite nicely. For example, we do all our scans at 7:30 to 9 in the morning, so women can come and have their scans first thing without having to take time off work. So the whole process can really be fit in very nicely in a working woman's life, so that she can still consider having egg freezing. So this is my view on egg freezing, and as I said, I'm probably biased, but I would advocate it to my daughters. I've got 2 daughters, and if they touch 30 and they want to climb in different directions of their careers or their relationship, I would tell them, have egg freezing done.
That's really interesting. And actually, I didn't know that stem cell freezing was commercially available. I had no idea. I would have loved to have done that with my kids. But that's really interesting that you can just get it done in 2 weeks. And I know it's a costly procedure, but we know that your IVF chances are equal to the age of the egg, if that makes sense. So if you have an egg donor or a frozen egg, if you're 40 but your eggs from somebody aged 30, your chances are much increased, and your chances are the same of a woman whose eggs are that age. Am I making sense?
That's correct. You're 100% right. Yes.
Yeah. And can you freeze them for an unlimited amount of time, or is there a time limit? Are there any risks with kind of freezing and thawing the egg?
Sure, that's a good question. So at the moment, the legal limit of egg freezing in terms of years is 10 years. But in patients who are freezing it for medical reasons such as cancer, can store it for up to 55 years. But currently, for social reasons, women are allowed to freeze eggs for up to 10 years. However, this is up for public consultation, and we're expecting that the law around this may change and may allow women to freeze for much longer. But at the moment, it certainly allows women to freeze eggs for 10 years. And the reason for this limit, Sandra, is that so that the technology is not abused. We know for a fact that, as you rightly said, that the chances of getting pregnant are based on the age of the egg. So we also don't want women freezing their eggs in their 30s and then, having kids when they're 50 or 55, where there's more other issues such as welfare of the children that we're trying to create that comes into question as well. So we don't want technology to be abused as well. And this is where the regulator is really trying to have a very, very measured approach at technology not being exploited, but at the same time giving women the ability and flexibility to have children when they're ready for them. So certainly, that's where we're heading.
That's really interesting. And I have seen that there's a campaign ongoing at the moment, isn't there? And you made a really good point there that, perhaps age 55, you might want to think about whether it's, a good time to be having children when actually you're aging yourself. I mean, gosh, I can't imagine having a newborn in 15 years' time. I'm tired enough as it is.
And other thing you asked me was, should patients be aware of what the success rates are and with egg freezing? So yes, it's very important. So firstly, what patients need to be aware about is that at the current status of technology, we expect around 85% of the eggs that we freeze to survive. So a patient will lose 15% of the eggs purely from the thawing procedure, okay? Because it is a huge stress on the egg itself. So 85% of the eggs will survive. And out of these 80% of the eggs that survive, the chances of pregnancy are the same as fresh eggs, okay? So once the eggs survive, the woman's chances of pregnancy are the same, whether it was a fresh egg or whether it was a frozen egg. So the only stumbling block is that survival. But once the eggs have survived, then everything is as if it was a fresh egg.
That's interesting. And speaking of frozen embryo transfers then, because you've got the option of obviously having a fresh embryo transfer or a frozen embryo transfer. And I think I saw a few years back, was it a study that came out of Cambridge that was quite convincing that actually frozen embryo transfers had quite significantly higher success rates. But then there are quite a lot of different opinions on this. What do you think about this?
So the jury is still out on that. One of the biggest studies that is being done is on a national level, whereby they're comparing the outcomes from frozen cycles to fresh cycles. But on many levels, Sandra, everything has really moved towards frozen cycles. And I tell you why. One, there is more and more use of genetic screening technology now in the IVF area of medicine. So as I said earlier, almost 70% of our cycles are PGS cycles. So automatically, when you have to do genetic screening of the embryos, you cannot do a fresh transfer. So you have to freeze the embryos. So automatically that takes care of the patients who would have no other option to have a fresh transfer. But even in patients who are having are not having PGS, a lot of patients nowadays are choosing to just break their IVF cycle into 2 parts, simply because it just gives a much better patient experience. So as you may have heard, of course, patients feel that the ride is roughest in a way during stimulation because they're injecting themselves with hormones. And after the eggs are collected, they almost want their body to recuperate from the hormones that they have taken. So our recommendation as a clinic is also to try and break the IVF cycle in 2 parts. Part A, which is creating the eggs and collecting the eggs, and part B is transferring the embryo that has been created from those eggs. And in between part A and part B, let's give the body a bit of a rest, at least a month, so that all the hormones are washed out. And yes, you alluded to better success rates. Whilst there is still the jury which is out on it, the results are looking very promising on frozen embryo transfers. There are many studies that have shown at a smaller data set level that frozen embryo transfers are result in much higher pregnancy rate and live birth rates. And this is being attributed to the high estrogen levels that are present in a fresh embryo transfer, which are not present in a frozen embryo transfer due to the stimulation. So, yes, the direction is purely in many clinics going towards frozen embryo transfers for various reasons that I explained. One, which is genetic screening. Secondly, patient experience. And thirdly, the few studies that have shown a better output.
That's really interesting. And I actually had a client or a patient who, she's British, but she lives in California. And I had her come over and work with you or Dr. Batwala at your clinic because I was hearing things about what was going on in her cycle in the US, and I was horrified. But what I really liked about what she was advised to do, and I hadn't actually heard of that before she had it done, was so she had premature ovarian failure, or that was her diagnosis. But she was advised to actually batch her eggs freeze. So she went through a series of egg freezing rounds before she then went into the transfer, partly because if you want more than one child and you have a small number of eggs left, I guess is the thinking that it makes sense to freeze as much as you can possible now rather than having the baby and then starting again in, say, 2 years' time. Is that something that's commonly done, or?
Yes, so you alluded to a very important point that many clinics forget to focus on, which is what are the couple desiring? Not just necessarily, we shouldn't just assume that a couple is there to have a child and one child. we also should be aware that if we make a patient pregnant, then that blocks another 9 months of her life. And things can change in terms of her fertility in those 9 months. So one of the first questions we actually ask in our consultation is, what is the aspiration of the couple in terms of their family, and how many children would they like? And that then shapes our consultation in terms of our advice as well. So if we have a patient who's got a very low AMH or a poor ovarian reserve, and she tells us that, okay, I'm aiming to have 2 children or 3 children, then the recommendation from our end is that whilst your AMH is low, and whilst we can work with getting a few eggs now, why don't we do multiple cycles to capture those eggs? Because we know that even if we leave it another year, that fertility is going to decline further. If we have the ability to collect 4 eggs right now and we delay it by another year, we may not even have those 4 eggs. We may just have 1 or 2. So whilst we know that fertility can decline with time, and here we have a couple who really want to have 2 children, and yes, her ovarian reserve is low, but still it can give us 4 or 5 eggs, then it's only the right thing to do is advise them on their options of having what we call batched cycles, which is 2 or 3 cycles of IVF, collecting the eggs and creating embryos, and then keeping those embryos for up to 10 years, which a couple have the chance to do anyway, and then use those embryos one by one in the pursuit to complete their family. So I think that's a very smart thing to do. Not many clinics are tuned to think that way, but we do. And you've rightly identified that in one of the patients that we've sent.
Yeah, I mean, I just don't even know why I've not heard of that before. But I mean, and she's so happy. I spoke to her recently. She's doing really, really well, and I know she's incredibly grateful to everything that you did. And it's so nice, as opposed for her to know that she can have the baby, she can choose to breastfeed. I guess if you're breastfeeding, you can't do another cycle until you stop, is that right? So, there's no kind of, it just removes that extra layer of stress, I suppose, about the future. Because, she said to me, I could have had 3 kids by now, and, they would be in school and all this, but just knowing that you've got more, that option is still there. I think it's, I imagine must be so comforting. I've just got one more question before I let you go. What is embryo glue, and what do you think about this?
So embryo glue is a specialized culture media which is very rich in what we call hyaluronic acid. And hyaluronic acid is a component which is very viscous. But most importantly, research has shown that when there is hyaluronic acid present in the culture media, the embryo has a higher rate of affinity to implant. So the embryo glue is a very generic, not a generic term, it's a commercial term. But the media has got a high percentage of hyaluronic acid in there, which assists the embryo assists the embryo to implant once transferred back into the womb. So the science behind this is that there have been some studies that have shown that the presence of hyaluronic acid in culture media also improves embryonic development, because embryos show the receptor for hyaluronic acid, but most importantly, even the uterus shows that receptor for hyaluronic acid, and hence it engages a bit of a crosstalk between the embryo and the uterus to aid implantation. But I want to say that the use of embryo glue cannot be a generic as much as you may think, but why wouldn't you use it on everyone? Because data has shown that it benefits a very small subset of patients and not necessarily every patient. So the group of patients that it has shown to benefit is patients who have had repeated miscarriages. So this is the group that I think we at IVF London, we focus on suggesting embryo glue only to patients who've had repeated miscarriages and not necessarily everyone. Because from a regulatory compliance perspective, the regulator also considers embryo glue as an add-on. So we have to have a lot of responsibility around recommending treatments that have got some level of proven data or evidence for. So, and hence, we offer embryo glue, but it's not necessarily for everyone, but a subset of patients.
That's interesting. I've only ever heard about hyaluronic acid. I can't even pronounce it. In terms of skincare, and it can help plump your skin and help it hold more water to make it look younger. So it's interesting that it potentially can help embryos as well. Thank you so much for your time. This has been so incredibly informative and interesting. And I'm sure people would like to know how to find you and contact you on social media and your clinic. Could you tell us how best to get in touch?
Sure. So thank you so much, Sandra, firstly, for obviously inviting me. And it's been a great engagement today with yourselves. It's been very stimulating conversation. I really enjoyed it. The way to get in touch with IVF London or myself as well is you can email us on info@ivflondon.co.uk. I'll repeat, it's info, @ivflondon.co.uk. You can visit our website on ivflondon.co.uk, or you can call us, and our phone number is 0208 207 4115. It's 0208 207 4115. And you can connect with us through social media handles as well. We're on all three platforms, on Instagram, Twitter, and Facebook. So thank you so much for your time. And I really, really look forward to, further episodes together. And thank you so much.
Yeah, thank you. And I think you forgot to mention you have a great YouTube channel as well, with lots and lots and lots of information about all aspects of assisted reproductive technologies as well. So, and we did an interview which is on there. So thank you so much. And I'm sure I'll have to get you back again to talk about all sorts of other questions. I've got another list of questions, but I've talked to you for a long time now already. But yeah. It's been really brilliant. So thank you so much.
Thank you, Sandra. Thank you. Stay safe.
Well, I learned so much from that chat, and I really hope you enjoyed listening to this episode. I'd love to connect with you on social media. You can usually find me on Instagram. My handle is @SandraGreenbank_fertility. And I'd love it if you would leave me a review as well. If you wanted to take a look at my fertility course, the link is in my Instagram profile. And at the moment, if you're listening during July or August 2020, if you use the code LOCKDOWN, you get £100 off. And please feel free to send me any questions. You can DM me on Instagram, or you can email me on hello@sandragreenbank.co.uk.